Okay, in this video we're going to get into the complications of having chronic kidney disease. And so before we get into that, it's important to think about what are the basic functions of the kidney. And so I've listed these out right here. So number one is to participate in sodium and water balance. Okay, another is to participate in potassium balance. Another one is to regulate acid-base balance of the body, regulate the hemoglobin. Also in bone and mineral metabolism. The calcium is very important for regulating calcium and phosphorus balance, as well as producing active vitamin D or calcitriol. And also the kidney has an important clearance role in terms of clearing uremic solutes and other toxins or drugs that we may ingest. Now it should be easy to think about the complications of chronic kidney disease. So if a sodium and water balance is impaired, this can lead to hypertension. Retaining sodium leads to fluid overload, so patients can develop edema. And also, if you're unable to excrete water, right? So if you're retaining water, patients with CKD can develop hyponatremia. Same thing for potassium balance. So if potassium excretion or secretion through the kidney is impaired, patient can develop hyperkalemia. If the kidney is unable to excrete these non-volatile acids that are produced from our diet and metabolism, we'll have a tendency to develop a metabolic acidosis. If the kidney is less able to regulate the hemoglobin, it's not uncommon to develop anemia, so an anemia of chronic kidney disease. If bone and mineral metabolism is impaired, patients with CKD can develop hyperphosphatemia, and they develop hyperparathyroidism as a consequence. And then, of course, if clearance is impaired, usually at later stages of chronic kidney disease, symptoms develop from retention of uremic solutes. And then also, for any medication that is, reliant on renal clearance, if the, GFR is low and the drug accumulates, patients can be more prone to develop side effects or complications of that medical therapy or that drug. So certainly something to consider as the GFR declines. So given these complications of CKD, you may be wondering, what's the relative prevalence of each complication based on what the GFR actually is. And so these are crude estimates, from population-wide data of patients with CKD. And obviously, every patient is different, and every patient doesn't fit this mold exactly, but it does give you sort of a broad range of when you'll see different complications. It gives you a best guess, rather. And so it's important to note, look, hypertension is quite prevalent, even at higher GFRs, and obviously increases as the GFR declines. The next complication, anemia of CKD and hyperparathyroidism starts to become more prevalent once the GFR gets below 60 and increases as it declines. Metabolic acidosis, as well as hyperkalemia, you can see it starts to develop once the GFR is below 40 or so. Hyperphosphatemia, this can start to develop at least once the GFR is below 35, hitting 20 or so, and then it can increase in frequency. Usually when the GFR is 15 or less, patients can develop hypervolemia or edema, but of course, if a patient has another comorbidity that makes them retain sodium, this could obviously develop earlier. And then symptoms of uremia from retention of uremic solutes tends to develop when the GFR is below 10 or so. So like I said, this just gives you a general snapshot. Every patient will be unique. Before we go into each complication of chronic kidney disease separately, I want to talk about the balance concept. So this is very important for kidney physiology, as well as understanding chronic kidney disease. And essentially, the balance concept is that we want the amount in to equal the amount out. So whatever is produced, from diet, from metabolism, we want to be able to maintain concentrations within the normal range, but things become abnormal if in does not equal out. And so our main way to get things out of our body is either through insensible losses, stool losses, or renal losses. And so anything that's regulated by the kidney, right, if it's regulated by the kidney and the kidney's not working well, it can accumulate because the out mechanism is not working as well. So as long as the intake, remain stable in terms of our diet or metabolism, but the out is failing, we have to deal with these in some other way. And so this is one way to think about the complications of CKD, is to understand the balance concept. So when the kidney's working normally, in equals out. The things that the kidney handles, it will increase excretion to handle a change on the intake side. But if we have fewer nephrons and we have chronic kidney disease, there's less kidney machinery there to process. And so this is partially what leads to complications of chronic kidney disease. So let's go through them. Here's our schematic for the body and how diet intersects with chronic kidney disease and cardiovascular outcomes. So first, let's talk about sodium. So now we're looking at sodium, and look, it's being reabsorbed by enterocytes. And so because sodium is a small ion, it's handled by the kidney. So a lot of it is filtered. And so it gets filtered by the kidney. And so how the kidney handles sodium along with another anion obviously determines the volume status as well as whether or not you're going to develop hypertension. So primary sodium retention is one mechanism for why a patient with chronic kidney disease would develop hypertension. But remember, there are other inputs that can affect the kidney, such as the sympathetic nervous system influencing sodium retention, as well as the renin-angiotensin-aldosterone system. So this comes from within the kidney. So let's say if the patient has local ischemia to the kidney, it could sense that ischemia and secrete renin in response to that, and that will eventually lead to sympathetic nervous system activity and primary sodium retention, as well as a vasoconstrictive effect, primarily due to angiotensin II and then later aldosterone. So the net effect of all of this is to develop chronic hypertension, which we know is not good because it leads to bad cardiovascular outcomes, such as risk of MI, right? A risk of congestive heart failure, or especially a type of cardiomyopathy called LVH, or left ventricular hypertrophy, and also just increased risk of stroke as well. So in order to reduce the risk of these events, we know that lowering the blood pressure in patients with hypertension can help. And so, the kidney plays a role in this. And so we pay close attention to blood pressure as well as hypertension in patients with chronic kidney disease. Another concept relevant to hypertension and CKD is the concept of glomerular hyperfiltration. And so this is where there's actually intraglomerular hypertension, or increase in filtration at the level of the glomerulus that's above and beyond what normally needs to happen. And so what's essentially happening is that there is preferential vasoconstriction of the efferent arteriole, that's the efferent arteriole on this side, with preferential vasodilation of the afferent arteriole on this side. So here's the afferent arteriole, here's the efferent arteriole. And so with preferential vasodilation of the afferent, you're going to bring in more blood flow right into the glomerulus. And then with efferent vasoconstriction, you're going to essentially increase the pressure here in the glomerulus. So this process appears to occur after nephron loss. So it's an adaptive hyperfiltration after, let's say, there was some insult to the kidney, or the patient has polycystic kidney disease and they've lost a number of nephrons, or they're losing them. Hyperfiltration will occur in the remaining glomeruli of the normal nephrons in order to sort of boost the GFR back to normal after that insult. However, what we've discovered is that hyperfiltration, no matter whether it's adaptive or maladaptive, it's not good for podocytes, it's not good for the glomerulus, and it can lead to chronic podocyte damage and loss and eventual glomerular scarring. So when we're treating hypertension, we're also trying to mitigate or slow down this adaptive hyperfiltration process. Most importantly, some common causes of glomerular hyperfiltration. Number one, diabetes. Obesity can do this. Hyperfiltration occurs right after a high protein meal, which we're going to get into later. But really anything that caused, nephron loss leads to this adaptive hyperfiltration. And so, like I said, whether it's adaptive or maladaptive, we do know that, chronic hyperfiltration is not good. It's damaging to podocytes and actually leads to progressive glomerular sclerosis. So, especially when we're thinking about treating hypertension, seeing albuminuria or proteinuria is a sign that there's podocyte damage occurring. And so mitigating hyperfiltration can reduce the proteinuria and then reduce glomerular scarring and extend the life of the kidney. And so that's part of the reasoning that goes into how we treat patients with hypertension and CKD, and we're going to get into that. So in terms of our approach to treating hypertension among patients with CKD, we care about whether the patient has proteinuria with their CKD or no proteinuria with CKD. And so who has proteinuria and who doesn't? So an albumin-creatinine ratio greater than 30 milligrams per gram of creatinine, or that probably corresponds to a protein-creatinine ratio greater than 150 milligrams of total proteinuria per gram of creatinine excreted in the urine. And so, less than 30 albumin-creatinine ratio, less than 150 protein-creatinine ratio would be a patient without proteinuria. So for the patients with proteinuria or albuminuria, we have two key learning points. Number one, the goal, and this is based on KDIGO guidelines, which is based on many studies. So the goal blood pressure is get the systolic less than or equal to 130 and the diastolic less than or equal to 80. The second key learning point is to use either an ACE inhibitor or an angiotensin receptor blocker. So keep in mind, remember the last picture we looked at, we were talking about glomerular hyperfiltration. So what we want to do is reduce intraglomerular pressure, and so these medications will do that. By blocking the action of angiotensin II, they will release constriction on the efferent arteriole. Efferent arteriole will vasodilate a little bit, and that will reduce intraglomerular pressure, and that can mitigate or slow down the hyperfiltration process and reduce podocyte damage. So this is key for the CKD patient with proteinuria. Use ACE or ARB. So for patients with CKD hypertension but who don't have proteinuria, so I define that here. So here are some goal blood pressures, and one thing with blood pressure goals and targets and definitions, it's a rapidly changing field. Definitions change all the time, and so as of right now, the last KDIGO guidelines said that for a patient without proteinuria, the goal blood pressure should be less than 140 over a diastolic less than or equal to 90. But recent American College of Cardiology joint guidelines in the year 2017 suggested that a patient with CKD, as they have higher risk for cardiovascular disease and bad cardiovascular outcomes, should start treatment when the blood pressure is above 130 over 80 to try and get it below less than or equal to 130 over 80. So, as I said, guidelines and definitions may change over time as new studies come out, and there's always a little bit of disagreement, but I think this gives you a good idea about where to go. And for this group without proteinuria, you don't have to use an ACE inhibitor or ARB like you do in the proteinuria group. In the group without proteinuria, you just want to get the blood pressure to goal. And remember, the point of this is to prevent bad cardiovascular outcomes. In the group with proteinuria, we do know that using ACE or ARB to reduce intraglomerular pressure, that actually does slow progression of CKD and leads to better renal outcomes. So that's the importance for that recommendation. Clearly, we want to slow the progression of CKD, and of the proteinuric patients, using an ACE inhibitor or ARB is key to doing that. And just a quick review of some pearls regarding hypertension management in CKD patients. So, first-line medications still apply, so thiazide diuretics, especially chlorthalidone, or calcium channel blockers, or ACE inhibitors, or ARBs, those are all fair game for treating a patient with hypertension. Remember, if the GFR is below 30, you probably need to switch from a thiazide diuretic to a loop diuretic, as a loop diuretic is more efficacious at natriuresis. Also, if a patient has resistant hypertension, and this is defined as a patient who's already on 3 antihypertensive agents, they're already at max dose, and one of those drugs is a diuretic, right? If they're still uncontrolled, that's resistant hypertension. In that setting, spironolactone or eplerenone, which are aldosterone antagonists, are indicated. And then keep in mind, beta blockers are not considered first line unless the patient has coronary artery disease or heart failure with reduced ejection fraction. Then it's obviously indicated to use those. And then, I know we've mentioned this before, but if the patient has proteinuria, definitely use the ACE inhibitor or the ARB. Next, of course, aside from using medications, there are many lifestyle recommendations that can help treat hypertension. So these come from the KDIGO guidelines on managing hypertension and CKD. So keeping the BMI between 20 and 25, low salt intake of less than 2 grams per day, regular exercise, and then also limiting alcohol intake. So 2 drinks or less for men and 1 drink or less for women. So combined with medications, the lifestyle changes can really have a big impact on blood pressure and hypertension.